I am Greg Morris. I'm actually CEO of Ascending to Health Respite Care. Let me throw out two things to you. So, two statistics that actually we want to try to make the biggest impact on. And number one is that the average homeless person will die 30 years before their house counterparts. That is probably the biggest focus and mission of Ascending to Health Respite Care. The other statistic is, and I'll give you the antiquated statistic in that 90% of all homeless will end up back in the hospital within 90 days of discharge for complications due to the diagnosis that they were discharged with. And that's simply because that there are other priorities for a homeless person, especially somebody that's on the streets, that don't center on regular discharge planning and caring for the illness that they were hospitalized for. And so that's where Ascending to Health steps in, is to offset the need to go back to the hospital and to prevent readmissions for a diagnosis that they shouldn't be readmitted for. Those statistics have changed slightly now, because I was actually part of a committee that helped develop CMS, which is Center for Medicaid and Medicare Services, proposed guidelines for hospitals to follow in discharging Medicare and Medicaid patients, so that hopefully they will consider other options aside from just discharging back to the streets or discharging to hospital beds where they really can't care and continue the discharge plans that have been given to them. But it's some of the statistics that came out from that now is it's no longer 90 days. Within the first few paragraphs, it actually says that 50% of homeless will end up back in the hospital within 1 week of discharge now. And 75% will end up back in the hospital, and I mean accessing the emergency department, within 2 weeks. So those numbers have really become condensed, and the need for respite care has risen greatly. And so what Ascending to Health Respite Care does is that we have a team of individuals very distinct in their duties that wrap around homeless individuals that are needing to be discharged from the hospital, and we place them into a setting in which they can recuperate safely and follow their discharge planning instructions. And so some of our case managers are responsible for taking them to their follow-up appointments. So if they need to go to ortho for a fracture, or if they need to go to GI for stomach issues, then we actually help them coordinate those appointments and make sure that they get to those appointments. And then we help them follow any of the instructions that they need to follow once they're following up from those appointments. We have a SOAR individual, which is, it's an acronym for Social Security Outreach, Access, and Recovery. If there's a bread and butter that is part of our organization, it is that position, because it's responsible for vetting through the individual's disability status, seeing what they qualify for, seeing maybe what they've lost and need to reacquire, so that they can get that income, and hopefully we can end their homeless status by the time they've been discharged from our program. And she will also help to try to coordinate access into assisted living, reconnect with families, or help them set up their own apartment at times. Our recuperative care program also employs a registered nurse as the manager, and so she does daily health assessments and tries to educate on maybe nutritional how to help from a nutritional standpoint support their chronic disease, so that they can adapt to healthy eating habits by the time they leave, and basic instructions on how to care for their chronic disease if they're hypertensive or if they're diabetic. And she's a great asset, and she's also the manager of the program. The recuperative care has 8 men's beds, and I will show that to you actually here in a little bit, and 3 women's beds. We partner directly with the social workers in the hospitals who coordinate discharging by sending referrals, and I had a referral here, which I can't show you actually, but I had a referral, so I could actually show you that we do get referrals almost daily, on a daily basis, for somebody that needs to be discharged. But we coordinate with them and actually make sure that the person is transported from the hospital to the respite care setting and into our services without an interruption. Sometimes we'll actually even go into the hospital to evaluate the person and make sure that they're comfortable with coming into the program so that they're not going to this unknown entity, and provide them the information that they need as far as the services that we will provide them. But it's the first program that we actually started. So the recuperative care is kind of blurring some of the lines of how our organization will look down the road, because it was the first the first program that we implemented. It's originally designed to be for those that are a little less ill, that maybe need 1 or 2 weeks to recuperate, maybe from a sprained ankle or a minor fracture or a very mild pneumonia, in which we can wrap these case management services around them and really try to change their homeless status. Now, we don't really think that we can probably do that in 2 weeks, but if they're continually discharged into our program, each time that they hit our services, we may move a little bit further forward, so that at one visit, we can maybe take them from the streets and put them into permanent supportive housing, for example. But because it is our first program, we take anybody that we feel that can benefit from our services. The biggest requirement is that they need to be in full capacity of their activity of daily living. So they really need to be able to change their own clothes and go to the bathroom and feed themselves. That's basically the requirement that we follow. We try to take anybody else that we think that we could help. Later on down the road, though, these programs will be split out. So recuperative care will actually function in the capacity that I just described, but we will implement a medical respite. And that medical respite will actually have oversight with medical providers, whether it's a mid-level provider or a physician, a nurse to manage the program, and an LPN. And different personnel to staff so that we can make it a 24-hour unit, so that they will always have somebody there that can monitor their needs around the clock. Those individuals will actually be able to stay up to 30 days or longer based on their medical needs. And then the recuperative care will revert back to those 14 days. So actually, if you want to pan around to the office, this is the administrative office where we do the case management. If you really look at this, we have the case managers on top of the manager of the unit, as well as a little makeshift kitchen. So at any given time during the day, we can have clients that are in eating, as well as clients sitting down with case managers. And this is how much we've actually grown in the past couple of years.
But that's where the Northern Lights are. You will sit and cheat and that would be
And this office is actually located within the Salvation Army Montgomery Center shelter.
We work fast.
That's Chris over there. He's the client navigator. This program doesn't work without him. This is Barb Cotter. She's business development. Not for a short while. Your retirement has been denied. So.
She's heard that for a long time. Yeah. Make me.
If you'll come with me this way, we'll kind of cruise through and take a look at some of the beds that we have.
She's tethered. I know. Well, we'll pull that right out.
Now, this is the main kitchen of the Salvation Army's Montgomery Center. We share the kitchen with our clients. During lunchtime, they will actually come into this area and they can sit down and eat lunch and don't have to access meals off-site like most of the other residents need to. This area that we're kind of looking at now will become our kitchen facility. So we'll actually be able to move the kitchen services that we have on top of the case managers out of the office, and the case managers will then be able to do their case management in a little bit more peace and quiet. So we're going to move towards the men's side. This is a Salvation Army shelter, so the men are separated from the women. We have 8 beds on our men's side and 3 beds on our women's side, and that's about the ratio of referrals that we get from the hospital. We've been running at capacity now for probably close to a year with maybe only a couple week dip in referrals to where some of the beds were empty. But come with me this way. Actually point this way. So this is our men's recuperative care unit. We have 8 hospital beds in here. We got the beds actually donated from a local hospital that is no longer a hospital. It actually became part of a local community health center. As you can see, all the beds but one are full at this time. But each has his own bed, is responsible for his own area as far as upkeep and whatnot. Now on the women's side, we won't be going over to the women's side, but there are 3 very similar beds in a very separate part of the shelter. Now what's exciting about this is that the area that you're looking at now is going to be part of our renovations so that we can actually start the process of separating ourselves from the shelter. So these little half walls will come down. This wall that my hand is on right now will actually go up to the ceiling, and the unit will become separate. Each bed will be separated by a little half wall. It will be wired with the potential for monitors and maybe TVs. So that there's a little bit more privacy and there's a little bit more ability to render care separately. Let's go around this way. And then adjacent to this will be another room with 3 more beds and a separate office. The office is very important because then we can actually perform exams on site. We don't have to take them off site or follow up with specialists for some minor things that we could potentially do here. Although part of recuperative care, and one of the bigger things that we want to accomplish is the access and the use of a primary care provider. So as part of their stay, it's actually required that they are attributed to a primary care provider, an appointment is made, and we make sure that at least keep one of those appointments. And in some appointments, and in some of those cases, that appointment has been the first appointment the individual may have had in 1 or 2 years or more. So. And then that kind of encourages the use of a primary care provider instead of the hospital's ER as a primary care access. So, and this is our men's unit, so we're excited about this. Now, the final thing that I want to say is that I mentioned earlier that there was 3 components of our organization. I haven't mentioned the third component, and that's our permanent supportive housing. We actually have the ability to take individuals that qualify, and this is a HUD-funded program, that qualify for housing per HUD's guidelines, and we can literally transition them from the recuperative or medical respite setting into our own housing units, thus ending and breaking the cycle of homelessness. So we're very excited and proud of that. We've had 3 units that were funded by HUD for the past 15 months, and so we're kind of new in providing this housing. We're kind of wading through the heavy restrictions and guidelines and protocols, but it's been exciting. All 3 individuals have stayed in their housing unit to date. We fill a specific criteria of homeless that go into those housing programs. They have to be chronically homeless, which it means 1 calendar year on the streets or in a shelter, or 4 episodes of homelessness that total 1 year over a 3-year period. But they also have to have a disability as well. And so we're kind of taking care of individuals that have very severe health issues. Of the 3 that we have in housing now, that will probably be their last place of residence. So 2 may move on to assisted living, and 1 will probably move on into hospice. But at least as they're approaching end of life, they've had a house that they can call their own, that they're proud of, and they can approach end of life with dignity. And we're proud to announce today that because of some of the operational reserve that we've had off of those 3 units, we are now able to open up a 4th unit. So we have 3 housing units plus 1 and 4 individuals that are out of homelessness. So And that is our Sending to Health Respite Care program.